This module focuses on assessment, and it will teach you how to think about and plan for your holistic nursing assessment of your patients. The learning outcomes for this lecture are that you will be able to differentiate between the holistic health and focused assessments, that you'll be able to relate the purpose of conducting an initial comprehensive head-to-toe physical assessment, that you can demonstrate the accurate use of each method of examination, inspection, palpation, percussion, and auscultation, that you can discuss factors required to ensure the completion of a timely assessment in practice, and that you'll be able to accurately interpret normal and abnormal findings obtained from the assessment. Nursing assessment is one of the most critical parts of the nursing process. When we talked in the last lecture about ADPI and about the NUR concept of clinical judgment, one of the key factors involved collecting data or assessment. And during your assessment, you're going to pick up on subtle cues that will point you into the direction of what is going on with your particular client. Now, I know in your current role, you may perform assessments that are more focused or streamlined, but as a nurse, you'll be able to perform an assessment. You may perform assessments several times throughout one shift. You may have the same patient for several days in a row, and so each assessment will tell you something, and you'll be able to detect if your patient is improving or declining based upon your assessment skills. We have, of course, baseline assessment, which is that assessment at your first encounter with your client. It's what we compare all the future assessments against. There is the comprehensive assessment, and that typically is when a patient is admitted to the hospital or upon their first entry into the healthcare system, they have a complete physical examination performed. Focused assessment is when a patient presents with a specific complaint. So, for example, if the patient presented with complaints of a cough and increased mucus production, they would have a focused respiratory assessment. The patient's chief complaint, whatever their presenting problem, and their clinical manifestations, so those signs and symptoms that they report and that you observe, they can help direct the focus of the assessment if it's for a specific complaint. Ongoing assessment is when you, like I mentioned earlier, you're performing ongoing assessments throughout the shift, or for example, for labor patients, we perform ongoing assessments of their fetal heart rate monitor and their vital signs. We may do that every 15 minutes throughout labor, so that's an ongoing assessment. So it involves an increased frequency of assessments. Whichever assessment that you are completing, not only is it essential that you know the process that you're going to do your assessment in, but you also need to make sure that it's organized and that you have a systematic approach to doing it, because that assessment, again, is going to be what your whole plan of care for your patient evolves around. The patient interview is that first component of getting a patient's health history. And it's during that time that the nurse and the patient work to establish a therapeutic relationship with one another. At that point, the nurse is constantly observing the patient, not necessarily through physical touch like they would during the assessment, but through observing their habits, maybe observing the patient's hygiene. They're collecting subjective data from the patient. What is the patient reporting as their signs, or their symptoms of their condition? it's an important time because it's the patient's first impression of the overall healthcare system as a whole, and whether they can trust the healthcare provider or not during this time. That's what they're figuring out. And so as the nurse, it's important that we are professional, that we are active listeners, we allow them to answer the questions without interrupting, that we show not any kind of particular preference, that we're non-judgmental, that we really try to empathize with the things that they are sharing with us so that they do trust us and so that they do feel comfortable sharing things. Maybe they are homeless, but they don't want to tell anybody, but you show that you're compassionate and you're non-judgmental from their appearance or whatever clues they might have given you, and they open up and tell you that, and then you're put in a position that you can help them. So it's a really key part of getting to know your patient. There are several phases. There are 3 phases: orientation, working, and termination. And during that orientation phase is when the nurse is going to introduce themselves, the patient introduces theirself, and they both work towards that goal of establishing a therapeutic relationship. Again, at that same time, the nurse is assessing the client's needs, how they're coping, their strengths and their weaknesses. But different barriers can arise and make it difficult to establish the relationship during that phase. If the patient is very anxious or if the patient is in severe pain, then the relationship might not form as it would were those things not present. So there can be barriers to establishing that therapeutic relationship. In the working phase, the nurse and the patient can try to overcome those barriers, and so they're actively working on goals that they've established in that first orientation period. And the nurse and the patient, they try to overcome any of those barriers, such as the anxiety, fear, or apprehension that may have occurred in that initial phase. The nurse is supporting that patient in developing new behavior by identifying support systems for the patient. And even though they're overcoming such barriers, there still can be some barriers in collecting the data that they need or interpreting the data that they do collect. In that termination phase, the 3rd phase of the patient interview, the nurse is discussing the progress that the client has made and considering whether that client needs any particular referrals. It can be difficult for the patient to separate from the nurse during this phase, and the nurse needs to be prepared for that. Early preparation is key in supporting the patient's separation from the nurse during that final phase. And the nurse may need some support as well from a colleague or from a supervisor if they are having difficulties separating from that patient during that termination phase. The health history is primarily going to consist of subjective data. This is the data that's obtained through that verbal interaction with the patient or the family, and objective data is going to be gathered through observation and the review of past medical records. The nurse is going to talk with that client during this history and take about why they've come for care, why are they seeking care, what's going on with their present illness, what kind of health history do they have. Do they have medications that they take regularly or any kind of herbal supplements? What's their past medical history, surgeries, prior hospitalizations, or other pertinent health data? Again, are there family history factors of hypertension, diabetes, cancer? You can detect issues if they have certain nutritional habits. Have they lost a lot of weight recently or gained weight? Those can be indicative of certain conditions. Do they have certain spiritual or cultural needs? What are their psychosocial needs? Are they abusers of drugs or alcohol? Have they been victims of physical or sexual abuse? Are their basic needs met? Do they have a house to live in? Do they have running water, lights? Do they have an advance directive or a living will? Those factors or those findings are all going to be what the nurse is searching for during that interview. During the review of systems, the nurse is collecting the subjective data about each body system, any changes or altered function that the patient may have. And so during the review of systems, it's more likely that the nurse is going to ask yes/no questions, whereas in the other parts of the interview, there'll be more open-ended questions. Objective data is collected during the physical. And again, those closed-ended yes or no questions are acceptable during the review of systems and at some points in the interview, but you really want to limit those to those questions like, do you have a history of, yes or no? Have you been a victim of, yes or no? But then you can always follow that up with a more therapeutic, more open-ended question, such as, tell me more about your experience with that, or share with me your beliefs about such and such. During the patient interview, the nurse needs to be aware again of factors that might affect the interview. Make sure that you're in a private area. Consider who's going to be the best source for the information that you're collecting. Of course, we hope that it's the patient, but if the patient is in severe pain, if the patient is maybe challenged in some facet, then they may not be the best source for data. So the primary source is considered the client, and then the secondary source would be considered family members, caregivers, support people, etc. Limit any kind of distractions during the time that you're doing the patient interview. You want to avoid interruptions that are not, necessary, because it causes both of you to lose your train of thought. Maintain confidentiality and assure the patient that you're going to maintain confidentiality. You can even explain to them about HIPAA and how everything that they share with you is to remain private and on a need-to-know basis. And you want to have enough time to do a good interview. You don't want to be rushed. So allow that time. If you are perhaps doing an interview on a patient and you have some other patients that you are overseeing their care, you may want to ask a colleague to step in and look after your other patient load for you so that you can devote this time to your patient that you're trying to interview. Remain relaxed during the interview and ask those open-ended questions or follow-up questions. Try to avoid using a lot of medical jargon that would be complicated for the patient to understand. Keep things simple, and again, make sure that you're observing those nonverbal cues. If the patient is not primarily English speaking, it is essential that you have an interpreter to translate for you. The interpreter should not be the patient's family member. The interpreter should be the hospital interpreter or the language line that the hospital uses. Legally, you are responsible for ensuring that the patient gets the care that they need, and if you use a family member, it can impact the communication because you don't know that the translation is correct. You don't know that the family member is understanding exactly what it is that you are needing to find out. And so for legality purposes, you should get an interpreter that is hospital approved, or use the language line that is hospital approved or facility approved. During your encounter with your patient, if you notice that the patient is tearful, the patient has blotchy skin, nervous tics, or maybe they're folding their arms in defense stance, those are all negative nonverbal cues. So you have to be really attuned to those nonverbal cues, those of physical appearance and mannerisms that the patient may present with. And focus on having a nice, orderly, and logical flow to your interview. You don't want to be jumping around from here and there and everywhere. You want to have a nice, consistent flow. The physical assessment portion of the history and physical is your collection of data. It's when you are collecting that objective data through your actual assessment of the patient. So remember, we talked about subjective data being what the patient is telling you. The patient's information from their point of view, so their symptoms. I'm feeling nauseated, I'm feeling anxious. Those are in quotations, and they would be subjective data. Objective data is something that's observable and measurable. So I observe the patient has increased respirations of 28 breaths per minute. That's an objective data. I observe the patient has pale skin and decreased heart rate. That would be objective. Whereas the patient stating, I feel like I'm going to pass out, in quotations, you would put that, and that would be subjective. So remember, objective is observable and measurable, and subjective is subject. It's the subject's view, the point of view from the subject. During that physical assessment, before beginning it, make sure you have the necessary equipment. Make sure that the equipment that you need to use is functional, and that you arrange it in the order it will be used. You don't want to have an otoscope the first thing at the bedside, and you're not going to use that first. You're going to use a blood pressure cuff, and you've got that all the way at the end of your line of equipment. So you want to have it in an orderly fashion. Of course, we stress that you use medical asepsis. You always need to use good hand hygiene before you touch the patient, anytime your hands get contaminated, and also at the end of the assessment. And explain to the patient what it is that you're about to do. Emphasizing privacy and confidentiality, it cannot be stated enough. Patients worry, especially in small communities, if they're familiar with you in a setting other than the hospital or the provider office, and they might think, oh my gosh, I went to high school with this girl and she knows all these things about me. You need to emphasize privacy and professionalism and confidentiality in that setting, and assure them that what happens there stays there. A good way to organize your physical assessment is to group techniques by position to keep that assessment systematic and organized. So you want to, move from the head to the toe. You want to focus on the head, moving down to the eyes, the ears, the nose, the throat, palpating the glands of the neck, the thyroid, and move down into the respiratory and the cardiac system, and so on and so forth. You don't want to, look at their eyes and then jump down and look at their feet. You want it to have a nice, progressive, systematic flow to it, to your exam. Not only does that help you, but it also provides a continuity between you examining someone and somebody else examining that same person. It allows for consistency in what we expect for the examination outcomes. There are 4 key assessment techniques that you should feel confident about, and those are inspection, palpation, auscultation, and percussion. Anytime that you have to auscultate the abdominal area, you want to auscultate anytime before you palpate or percuss that area, because we don't want to trigger a false presence of bowel sounds through stimulation. So always just remember that is to come first, auscultation before palpation or percussion of the abdomen. Of course, again, we stress hand hygiene. Anytime you're preparing to perform a physical exam, and then anytime your hands are contaminated, and at the end of the exam, make sure you're wearing appropriate personal protective equipment depending on the patient's isolation or standard precautions. When you are using inspection, you are using your vision. You're using your smell. You're scrutinizing physical characteristics of that person and their individual body systems. So you start your assessment by observing that patient's ability to, say, maybe ambulate. That might be something that you're observing. Then you're going to conduct the examination of each of your individual body systems using each person as their own control. So basing your assessment findings on what is normal compared to that patient's baseline. You should compare sides, so everything should be symmetric, left versus right sides of the body. When you are using palpation, you're going to use touch to assess various body organs, skin texture, temperature, moisture of the skin, turgor, tenderness and thickness. Consistency is what's going to measure the organ location and size against the expected anatomical norm. It's going to allow for you to palpate any kind of distension or masses, and also palpate any kind of vibration or pulsation that should or should not be present. Other findings: rigidity, crepitus, and the presence of lumps can be detected through palpation. You can make sure that you are observing the patient during palpation to detect any sensitivity or painfulness, and be aware of any nonverbal signs of distress or discomfort, like if the patient, for instance, starts to guard a certain area or complains of discomfort after the palpation, like in rebound tenderness. Those things should be noted. So palpation is going to follow your inspection. So inspection, then palpation, except once again during the assessment of the GI system, at which you would auscultate before you palpate and percuss. Various parts of the hand are best suited for assessment of different areas. So just keep that in mind. Also remember that palpation should be completed in a relaxed, gentle, systematic way, with tender areas palpated last. And you want to start with light palpation. Really deep palpation should be reserved for advanced practitioners, but definitely you want to start with light palpation in the initial assessment phase. So just to touch on inspection and palpation again: inspection, your visual assessment, your observation. You may even use your sense of smell during that inspection phase. You can compare the sides right to left. You also will, with palpation, again, palpating for temperature, moisture, texture, lump, swelling, guarding, tenderness, crepitus, starting with light palpation, and always making sure that your hands are washed beforehand and that they're warm. You don't want to put cold hands on someone. And when you are using palpation, you want to use caution to avoid injury to the patient. So just focusing on that light, gentle palpation and reserving the deep palpation for the advanced practitioner. Auscultation and percussion. With auscultation, you're going to listen to the body organ sound. You're going to auscultate the respirations. You're going to auscultate the bowel sounds. You're going to auscultate the heart sounds. And as the nurse, you must be able to differentiate between normal and abnormal. Always remember to clean your stethoscope in between patients. It's something that can be overlooked, but the stethoscope can carry many organisms, and you can infect a patient from contact with a stethoscope that's been used on another patient. So make sure to use rubbing alcohol or follow your policy and procedures for that institution as far as what you're cleaning your stethoscope with. Percussion is the tapping of the skin that causes a vibration, and so you might percuss over the liver. For instance, you're looking for sounds. Is the percussion sound flat? Is it dull? Is it resonant? Is it hyperresonant? Is tympani present? And depending on the organ system in the area that your percussion is occurring, will the sounds that you hear will let you know what's normal, what's abnormal. So another key factor when you're auscultating, when you're listening to the heart sounds, make sure that you have the correct side of the stethoscope in use. If you have the diaphragm, which is the flat side, that's going to allow you to hear high-pitched sounds like breath sounds and bowel sounds and normal heart sounds. The bell is the more concave, kind of like shaped like a cupcake, and that's used for assessing soft, low-pitched sounds such as extra or distant heart sounds and murmurs. Always, please use the stethoscope directly against the patient's skin. Anytime you're trying to auscultate sounds through patient's clothing or the gown, you can pick up extra sounds and it can make it difficult for you to hear what you need to hear. In the beginning of your assessment, your initial observations, you need to be focusing on the patient's safety. Do they use any kind of assistive devices such as hearing aids or eyeglasses? If the patient is in a hospital bed, are the side rails up ×2? Is the patient feeling any sense of concern over being harmed at home or in the hospital or anywhere? What is that general observation of the patient's safety status? You're going to note that, note their overall appearance and their behavior, and you're going to note their body image, their hygiene, their affect and mood, their gait, their speech, and their developmental status are all going to be your initial observations. And you compare that with what you would find in a typical patient. Is this norm? Is this the accepted behavior that you would expect for your patient? Patients should appear their stated age. If they have been a heavy smoker or been exposed to a lot of sun, they may appear older than their stated age. And you can actually document that. Patient appears older than stated age. Patient appears younger than stated age. Age is going to determine what exams and activities are recommended for that patient in their prevention of illness and health promotion. So that's why it's essential to find out, their age and document appropriately. Other initial observations might focus on their skin color, pigmentation, their hair texture and stature, their body habitus. Are they dressed appropriately for the weather, or are they inappropriately dressed for the weather? Those things can be a sign of an underlying medical condition like dementia, or either might be indicative of a psychiatric or mental health condition. Also keep in mind what would be cultural norms for that patient. So, you may have a patient that gives off a certain odor, but if that odor is because they have a certain cultural practice that causes that odor to be more prevalent, then that might be normal for that patient. And oftentimes when you're caring for patients who are of the LGBTQ community, those patients, they are very concerned about revealing their identity and sharing information. And so that essential part of establishing a therapeutic relationship will allow them to feel comfortable with you and divulge information that will help you to better care for those patients. Anytime you're asking patients about their safety, you want that patient to be in complete private. You're going to ask that patient's loved one or support person to please step out of the room while you ask those questions. And a lot of times you'll hear, oh, well, I know everything about them. They'll tell me. But if they're your abuser, you're not going to say anything in front of them. So it's very important to have that privacy. During this initial period, you'll assess their vital signs, their height and weight, and their body mass index as well. Your head to toe physical assessment, from the skin to the head and neck, to the eyes, the ears, the nose, the mouth and throat, the lungs, the heart, the musculoskeletal system, the nervous system and neurological system, your gastrointestinal system, and genitourinary system. Looking at skin, you can note the color. Maybe the color is jaundiced, which has a yellowish tint, like you see in the first image of the baby. Pallor, you can look at the inner part of the eyelid and see the paleness noted. Purpura, as indicated by the third picture, where you notice the red areas of across the forearm. I think that's the patient's forearm. You want to assess the skin in an area that has good natural light. You want to assess to note if the skin coloring is symmetric. You can also note things like, if it's a male patient, is there male pattern baldness? What the patient's sun exposure is like. Do they use tanning beds? Have they underwent recent chemotherapy or radiation? And a lot of times you can conduct this skin assessment while the patient's just sitting waiting in the examination room. If you need to examine the buttocks and the dorsal aspects of the legs or the lower torso, of course you can ask the patient to stand or position the patient on their side or their abdomen. You want to maintain privacy throughout the skin assessment, revealing only what portion that you need to inspect at a time and covering the remaining areas. And be very precise when you're documenting. You can use the Braden scale to reliably score patients at risk for the development of pressure ulcers. And again, other findings of the skin might involve cyanosis, which would be the bluish tint, vitiligo, which is the loss of skin pigment, erythema, which would be the redness of the skin caused by congestion or dilation of the blood vessels. So various findings can be documented in regards to the skin assessment. This slide you can see in the first picture is an example of age spots. There's the cherry angioma in the second picture, and then keratosis in the third. And those are all representative of benign skin lesions. Skin lesions can appear in a variety of shapes, sizes, and colors. When you identify a lesion, you need to inspect it for the size, the shape, the color, the location, and the distribution, and note any type of exudate that is associated with the lesion if it's present. You want to document the color and the approximate amount of that drainage, the consistency and odor. Pressure injuries are a big thing to be observant of, in any kind of initial redness that is starting. You want to keep a good close eye on that. Pressure injuries are a result of inactivity, infection, and consequence of poor circulation. So you need to be very observant for areas that pressure is often applied to, like the sacrum and the elbows, the heels, those types of areas. And of course, this is showing you signs of a primary lesion versus a secondary lesion. Primary arising from normal skin, secondary, which are seen in these two pictures, are a result of an injury such as pressure ulcer, scar, or wound dehiscence. Another portion of your skin assessment focuses on edema. So you will assess edema anywhere from 0, which is non-pitting, to +4, which is very deep pitting, approximately at 8 millimeters. You can see in this picture that looks like deep pitting there, but you'll see +1 edema, +2 edema bilaterally, +3 edema, or maybe the patient has +1 in one extremity and +2 in another. But it's important to document that. Common causes of edema might be trauma to an area, which is impairing the venous return. Edema secondary to poor venous return is usually most prominent in the lower extremities or dependent areas of the body. That skin might look very glossy, stretched, just depending on the amount of fluid that is actually present. If you go and you palpate that area and it leaves an indentation that persists, that is what's considered pitting edema. And then the number that you give it, the +1, +2, that degree of pitting edema is assessed by pressing that area with your thumb or forefinger for 1 to 2 seconds and then releasing, documenting that depth, the depth of indentation accordingly. So if you can indent it approximately 2 millimeters, then you have +1 pitting edema. If you know that you have a patient that has venous or arterial insufficiency, be very mindful of that, because even a slight pressure that causes indentation in edematous skin can produce trauma to their tissue. As far as inspection of the hair and scalp, you want to look at that hair pattern. Again, is there a pattern of male pattern baldness, alopecia, hirsutism, or excessive hair? What's the texture of the hair? Is it oily, dry, or brittle? Certain conditions, like those of thyroid conditions, often you can have certain expected findings in the hair. Is there head lice present, bed bugs, parasites, that sort of thing? So you want to wear gloves when you're doing the inspection and palpation. Well, not necessarily in the inspection, but when you're palpating the patient's hair and scalp, you want to make sure you use gloves. Nails, the older a person is, generally the thicker and more opaque the nails are. In this image, you can see an example of clubbing. And anytime you note clubbing of the nail beds, that indicates oxygen deprivation. The little moon-shaped area at the base of the nail is considered the lunula, and the most visible portion of the nail, obviously, is the nail plate. So you want to palpate the nails when you're doing capillary refill. You want to make sure that you palpate the nails to assess for texture and consistency, making sure that you know if the nail plate is firmly attached to the nail bed. And when assessing for capillary refill, you want to press on the nail bed for approximately 1 second and then release. As that pressure is applied, the nail bed should blanch or appear white, and then that pink tone should return immediately when the pressure is released. Of course, we know that we measure capillary refill in seconds, and it should be less than 3 seconds. Anything longer than 3 seconds would be considered slow or sluggish and is usually a sign of respiratory or cardiac disease. The head and neck. During assessment of the head and neck, asking important questions such as a history of a head injury, history of being unconscious, past history of dizziness, seizures, headaches. Of course, you want to follow up and ask more open-ended questions depending upon the answer. What are their general habits as far as when they bite? Do they wear a helmet? If they're in construction work, do they wear a helmet? And then as far as the head itself, checking for, any lumps, bumps, any abnormalities. What is the size and shape of the head? Facial expressions, any kind of tics that are present, and pigmentation of the head and the neck area. Moving along to the eyes, you're going to ask the patient, have they had any changes in their vision? And if so, then you need to follow up and ask them for details of that. Have they had a history of cataracts or glaucoma or eye surgery? Do they need eyeglasses or contact lenses? Have they noticed any pain or itching or discharge in their eye? And when was the last time they had an eye examination? This image shows you the picture of the eye from the I guess you'd say from the inner part out, because you can see the retina and the optic nerve, the macula, the iris, the pupil, the lens, and the other various eye anatomy. During the eye inspection and palpation, eye examination is going to include the assessment of normal eye structures, like extraocular movements and visual acuity. You want to determine the patient's level of eye function in relation to deficits or alterations that might impact things like ambulation or self-care or their activities of daily living. So again, thinking about that safety aspect, can the patient see well enough to perform their daily activities and to maintain safety? You would note if you notice any kind of strabismus or any kind of cross-eyed characteristics. What are their eyebrows and eyelids appear to look like? The conjunctiva and the sclera, is it clear? Is there any drainage from the eye? And then in this slide you can see some examples. Ptosis, which is called the drooping of the eyelid. There's ectropion and entropion. Ectropion being an averted eyelid, entropion being an inverted lid, and of course the kind of glassy whitish appearance of over the eye with a cataract. Physical examination of the eyes involves several components. One being an inspection of the eye for clarity, examination of the pupils, of course, to determine if they're round and reactive to light and they're able to accommodate. So there's various things that you're going to be looking for. When you inspect the cornea and you're examining that area for clarity, you're going to ask the patient to focus straight ahead, focusing on a point straight ahead while shining a light at an angle to cover that entire corneal surface, and you want it to look transparent, glossy, and even. It should not have any kind of blood vessels present. It's not a vascular area. And then you also want to assess for sensitivity of the cornea by taking maybe like a little wisp of a cotton ball to the outer edge of the cornea. The patient should then blink, and if so, that demonstrates that the patient's cranial nerves 5 and 7 are both intact. Clarity is better assessed during examination of the lens using an ophthalmoscope, so just be aware of that. If you have a patient that has lenses that are cloudy and they have impaired vision, that can indicate cataracts. And then while you're inspecting the area of the lacrimal gland, and you're going to palpate the upper and lower rim of the eye orbit, working from the inner canthus outward. If that lateral aspect of the upper lid feels full or the patient reports pain, you want to gently invert the lid and examine around that area, noting any kind of blocked ducts, because that could cause redness or swelling of the eyelids in the conjunctiva. You're going to inspect both eyes of the iris area, and you want to make sure they're clearly visible in the same color. And you want to examine the pupils for size, shape, symmetry, reaction to light, and accommodation. Normally, the pupil would be round, black, and equal in size between 3 to 7 millimeters. If the pupils are dilated to less than 2 millimeters, which is pinpoint pupils, and they fail to dilate, that can generally be caused by ingestion of opioids such as morphine or medications that control glaucoma. If the pupillary dilation is more than 6 millimeters and the pupils do not constrict with light stimulation, that can indicate trauma, neurological dysfunction, glaucoma, or ophthalmic drugs that have been introduced for examination of the eye or eye surgery. Reflexes of the pupils are evaluated when the area is dark and you use a pen light to check for light reflexes. You will approach from the patient from one side while asking the patient to focus straight ahead into the distance. They do not need to look directly to the light. The pupil closer to the light should constrict in response to exposure to the indirect light. Afterwards, the constriction of the opposite pupil, which is considered consensual constriction, follows, and then you repeat the procedure on the opposite eye. While assessing the pupillary light reflex, you will begin by approaching one eye with a pen light from the side. Again, observe the closest pupil for immediate constriction, followed by consensual constriction of the opposite pupil. When you're testing papillary reflexes for accommodation, that evaluates the ability of the eyes to focus on near objects. And it's only necessary to assess for accommodation if the pupillary reflexes are sluggish, absent, or abnormal in any way. If you have completed the assessment for PERLA, you can document that a normal pupillary reflex examination and record that as PERLA, P-E-R-R-L-A, for pupils are equal, round, reactive to light, and accommodation. And again, when you are assessing for that accommodation, that is going to be assessed when you have that patient focus on a distant object, and then on a pen or an unlit pen light, you hold it just a few inches from the patient's nose and you move the pen or the light closer to the patient's nose and look for their eyes to have bilateral convergence and constriction. I'm sure you all are familiar with that assessment. It's a lot easier to understand when you're looking at it versus reading about it on a slide. You have extraocular movements that you will assess in the eyes as well. Because of the nerves, cranial nerve 3, 4, and 6, which are the oculomotor, trochlear, and abducens, and the 6 extraocular muscles, they all help to control the movement of the eyes. You've probably heard of the 6 cardinal fields of gaze or of vision, and you perform this examination by having the patient seated or standing approximately 2 feet away from the nurse at eye level. You ask the patient to follow a finger or a pen just using their eyes, and you move through the 6 fields of gaze, moving the finger in a smooth gliding motion to the right, then the left, then diagonally within each of the patient's fields of vision, approximately 6 to 12 inches from the patient's eyes. Then you ask the patient to move the eyes to the extreme lateral position towards the ears, both left and right. And as the patient looks in each direction, you note the presence of normal, parallel, and equal eye movement and lid position or any signs of abnormal movement. If you notice nystagmus, which is a rapid shaking, involuntary movement of the eyes, that would be an abnormal finding, and it's especially noticeable when the patient is asked to look to the side and quickly return the gaze to front. It can occur in both eyes or in just one eye, depending on the cause. Sometimes things like inner ear disorders, multiple sclerosis, narcotic use, or brain injuries can be the contributing cause to nystagmus. The Snellen chart and then the E chart are both tests of visual acuity. And visual acuity is the examination of the patient's ability to see at a distance and a close range. And in this visual acuity assessment, you are assessing cranial nerve 2. When you're assessing near vision, you of course will ask the patient to read printed material at a comfortable distance, approximately 35 centimeters or 14 inches from the eyes in adequate lighting. If the patient normally wears glasses, they should be allowed to wear them during this part of the assessment. If you note that the patient is having difficulty reading, you can move on to other parts of the examination. The Snellen chart comprises increasingly smaller lines of letters and is used to test distant or far vision, and it should be placed on a wall or door at eye level. The patient would stand approximately 20 feet from the chart and cover one eye at a time, reading each line of the letters until they can no longer identify them. And E-chart can be used to test visual acuity with patients who are unable to read or unfamiliar with the English alphabet. Of course, if you are documenting a vision of 20/20, you are 20 distance in feet from the chart, and a person an average person can read at that same distance. If your vision is 20/30, it means you can read the chart at 20 feet, what an average person can read at 30 feet. 20/15 means you can read the chart at 20 feet, what an average person can read at 15 feet. And 2200 means that you can read at 20 feet what an average person can read at 200 feet. This Ishara test is a test for color blindness. And then we're moving on to examination of the ear. So during the physical examination of the ear, of course, you're going to begin with inspection and palpation of the outer ear. You're going to note the pinna, the tragus, and the lobule. The inspection portion is then you use an otoscope to complete that. You assess the middle and the inner ear by testing hearing acuity, sound conduction, and equilibrium. And you can see the various anatomy of the ear in this picture. When you use the otoscope and you visualize into the internal part of the ear, you will be able to visualize the malleus and the stapes of the ear itself in that middle portion. You're going to inspect the ear for any excessive earwax or cerumen, discharge, and if you note it, you want to make sure you document the color and the odor. Of course, you want to use PPE while you're doing so as appropriate. You can palpate the auricles in the mastoid area and detect if there's any tenderness in that mastoid area. And an advanced practice nurse, of course, would perform the otoscope examination. Hearing evaluation, you are going to assess auditory function initially just by documenting the patient's response to your questions and instructions. You'll ask if the patient has experienced any kind of tinnitus, which is a ringing, buzzing, or roaring in the ears, and that can be a contributing factor to hearing loss. It can also indicate overuse of salicylates, and it can also be a symptom of diseases such as vertigo or Meniere's disease. People, often as they age can end up losing some hearing just from aging itself, but also trauma, disease, medication, and prolonged exposure to high decibel sounds. So there are 3 types of hearing loss. There's sensorineural, conductive, and mixed. Those are the 3 types. Sensorineural hearing loss is because of inner ear damage that prevents sound from being converted to nerve impulses. Prolonged exposure to loud sounds and oxytoxic medications can be a contributing factor. Conductive hearing loss is what occurs when something interferes with the transmission of sound through vibration to the inner ear. So if there's fluid in the middle ear or excessive wax or cerumen, or if there's atrophy of the tympanic membrane. And then mixed hearing loss results from middle ear and nerve damage. You will assess the patency of the 8th cranial nerve by evaluating that patient's hearing acuity. The Weber test, it can be conducted if a patient complains of hearing loss in one ear, and you use a tuning fork to perform this test. The advanced practice nurse is who is responsible for completing this test. If the patient reports hearing sound from the tuning fork in the poor ear, then the nurse notes that lateralization of sound to the poor ear has occurred and that indeed conductive hearing loss has occurred. When that advanced practice nurse conducts the Weber test, they take and they strike the tuning fork softly with the back of their hand, and then they place the base of the vibrating tuning fork against the center of the patient's forehead, and then they should be able to detect vibration equally in both ears, and that would be a normal finding that indicates no hearing loss. The Rennie test, I'm not sure if I'm pronouncing that right, but the Rhine test or the Rennie test compares air conduction and bone conduction, and it is carried out by gently placing the base of a vibrating tuning fork against the mastoid process behind the ear. The nurse would then ask the patient to indicate when sound is no longer audible. And after the patient has indicated that sound is no longer audible, the tuning fork tines are then placed in front of the external auditory canal, and the patient is again asked to indicate when sound is no longer heard. The length of time that sound was heard by bone conduction versus air conduction is then determined. Now, normal finding is that air conduction sound should be heard twice as long as the bone conduction sound. If a patient has conductive hearing loss, they will hear bone conduction sound for longer than or as long as air conduction sound. If the patient has sensorineural hearing loss, the conduction sound is heard for only slightly longer than bone conduction sound. The inner ear is responsible for helping a person maintain equilibrium and that sense of balance. Patients who experience inner ear disorders often experience a loss of equilibrium and vertigo. The Romberg test is a test that's conducted to assess the patient's equilibrium, and you conduct this test by having the patient stand with their feet together and their arms at their side. They have their eyes open initially and then eyes closed, and they should be able to maintain their balance for at least 20 seconds without moving their feet or starting to fall. If they're unable to do so, it can indicate vestibular disease. In assessing the nose, you would ask the patient about history of allergies, sinus infection, history of trauma, nasal discharge, headache, snoring, do they feel tired after they sleep all night, history of nosebleeds. Those would all be important questions. During the assessment of the nose, you're going to inspect and palpate with the patient seated. You'll use a pen light to examine each nair and the surrounding structures. Using an otoscope or a nasal speculum would allow to assess deeper into the nairs, but that would be an advanced practitioner's role. You want to assess for any tenderness or swelling of the sinus cavities. Note any nasal flaring, presence of nasal polyps or ulcerations, any perforation noted, and of course, history of epistasis or nosebleeds. In inspecting the mouth and throat, an assessment of that area, you will ask about history of mouth or throat cancer, history of bleeding gums, cold sores, dry mouth, tooth pain, cracked lips, difficulty swallowing, and their last visit to the dentist. During the assessment of the mouth, throat, and the neck, you have the opportunity to evaluate an overall assessment of the patient's health status, including their oral hygiene, their condition of their teeth and gums, hydration status, airway patency, their ability to meet their nutritional needs, and their patency of cerebral blood flow. You're going to have the patient positioned in a manner that you can assess their mouth. You'll note their odor, the moisture, and the color. You'll assess their dental habits, their presence of any dental caries or cavities, their oral mucosa, the coloring of that, their uvula, tonsils, palate, and gums, their upper and lower jaw area, and you can have the patient say ah using the tongue depressor and use a pen light and be able to inspect the posterior area of the mouth. In the examination of the neck, you're noting lymph nodes. You're comparing them bilaterally, noting if there's any tenderness, consistency. If the lymph nodes are hard or immobile or tender or painful or enlarged, that would be abnormal. If they're enlarged, it can indicate an infection, a malignancy, or HIV even. Inspection, palpation, and auscultation of the neck would also involve looking for symmetry of the neck and symmetry of the sounds when you're auscultating in the neck area. For jugular vein distension, you're going to note that assessment is going to be done with the head of the bed at 45 degrees. If jugular vein distension is present, that indicates that there's an increased central venous pressure. You're also assessing the neck muscles for flexibility, strength, and any discomfort. A patient should be able to move their head up and down and side to side without any limitation or pain. They should have full range of motion noted during that assessment. Upon auscultation of the carotid arteries and palpation of the carotid arteries, it's important to remember to palpate one carotid artery at a time so as not to occlude those areas. You would auscultate for a bruit, which is a swishing sound, and that can indicate that there's a partial obstruction. So that would be an abnormal finding if you noted a bruit. Those carotid arteries are the arteries that provide blood supply to the head, so it's important to assess for patency of that blood flow. You want to note if there are bounding pulses. That would be abnormal finding. And again, you do not want to palpate them both at the same time because that would cause the patient to have limited blood flow and they could pass out. You palpate and then you auscultate the carotid arteries. Oops. And then you're going to palpate the thyroid. That's the last of the areas of the neck to examine, the thyroid and the trachea. So you're going to inspect the thyroid gland for position and enlargement. The thyroid gland is the largest endocrine gland in the body, and it produces thyroid hormones necessary to, of course, increase the metabolic rate of your cells of your body. It should be midline and be able to move up and down without any discomfort when the patient swallows. If there is thyroid enlargement present, that should be documented and further palpated by an advanced practice nurse or physician. With the respiratory system, you will ask questions regarding difficulty breathing, shortness of breath. You're going to inspect the chest for shape and configuration. You're going to inspect their breathing patterns, the use of any accessory muscles. Disregard where it says see page 287 because that is not in correspondence with your textbook for this semester. But using the accessory muscles would signify that the patient is having to exert respiratory effort and is having respiratory distress and would be an abnormal finding. The normal anteroposterior measurement of the chest should be less than the transverse. So the transverse being across the chest. The normal ratio should be between 1 to 2 to 5 to 7. You would want to know any kind of abnormalities of the chest, including lesions, scarring, or any grossly asymmetric features. And you want to observe the patient's breathing pattern during inspection of the anterior chest while the patient is breathing passively. For the adult patient, their respirations are going to be between 12 and 20. You want to observe the patient's position and posture during respiration. They should be relaxed with their arms comfortable at their sides or their hands folded in the lap. With cerebral palsy, rib fractures, any kind of severe skeletal muscle deformities like kyphosis, the movement of the patient's thoracic cage can be limited, and that can impact their oxygenation and cause a decreased oxygenation, which will lead to greater risk of infection from pooled secretions or air trapped in their lungs. And then patients who have chronic lung disease such as emphysema and COPD, you would note that in those patients, their AP diameter of the chest is often equal to the transverse diameter. And remember in the prior slide, we talked about how the AP should be smaller than the transverse. And in this situation, they're equal. When assessing the respiratory system and you're performing palpation, palpation of the chest after you have washed and warmed your hands. You will palpate from the shoulder area downward, looking for the presence of tenderness or any lumps. You'll also palpate for tactile fremitus. Tactile fremitus is a palpable vibration that occurs with voice. So you would ask the patient to say 99 as you palpate both sides of the chest to feel for that vibration that's transmitted through the chest wall during that movement of the vocal cords when the patient is stating that 99, 99. So the nurse is palpating for the tactile fremitus by placing the fingers of one hand on the patient's chest while the patient repeats the words 99, beginning at the top of the lungs and then palpating from one side to the other for comparison, and they should feel the same. If that tactile fremitus is decreased, it can indicate that there's an obstruction of lung tissue, like maybe pneumothorax or tumor or COPD. If that tactile fremitus is increased, it can indicate pneumonia or some type of consolidation close to the chest wall. You would evaluate the patient's chest excursion if there was a concern about chest expansion, and you would again place warm hands on the posterolateral chest wall with the thumbs about at the level of T9 to T10 on either side of the spine and moving your hands towards the spine medially to see if you can create a small skin fold between the thumbs. You ask the patient to inhale deeply through the mouth, and then you note your thumb movement during that inspiration and expiration. You want your thumbs to move apart symmetrically, about 3 to 5 centimeters. But if they're not moving symmetrically and there's asymmetric chest excursions, that could be a result of pain, deformity, postural anomalies, lung collapse, obesity, muscle fatigue, or weakness. The cardiac and peripheral vascular assessment. You will inspect and palpate the heart with the patient either in the supine position or with the head of the bed at 45 degrees. It requires that you understand the anatomy of the heart and the function of the circulatory system throughout the body. You will again assist the patient into that supine position or raise the head of the bed at 45 degrees, and you need to inspect and palpate following a very systematic sequence. So you would assess the right ventricle, then the left ventricle, right atrium, then the left atrium. You would assess using auscultation, and there's a mnemonic that's used called 8TM. A is the aortic area, which is the right second intercostal space. P is the pulmonic area, which is the left second intercostal space. E is Erb's point. T is tricuspid area. M is the mitral area, which is left fifth intercostal space, medial to the mid-clavicular line. And so that is the sequence in which you would want to auscultate the heart sounds. The first heart sound, or that S1 lub sound, results from the valves closing between the atria and the ventricles. The S1 sound is best heard at the apex of the heart. It marks the beginning of systole. The second, or the S2, the dub, corresponds to the closure of the valves between the ventricles and the great arteries exiting the heart, and that's higher in pitch and shorter than the S1 lub. The S2 sound is loudest at the aortic and pulmonic areas and marks the beginning of diastole. I said that terrible. You know what I mean. Systolic, diastolic. Okay, so it marks the beginning of diastolic action. A third heart sound heard immediately after S2 has a gallop. that follows the rhythm of the word Kentucky, and it is best heard at the apical site with the client lying on his or her left side. And then the fourth heart sound is heard immediately before S1. It has a rhythm that follows the word Florida. S4 is best heard at the apical site using the bell of the stethoscope with the client lying on his or her left side. It's normal in athletes and in some older clients, and can also be heard in adults with coronary artery disease, hypertension, and pulmonic stenosis. Again, you may also hear sounds, murmurs that they're called. They're additional sounds produced by turbulent flow through the heart. Most can be innocent, but others do represent that there's some kind of condition that needs to be investigated. Dysrhythmias, of course, are irregular heartbeats. A pulse deficit is when the radial pulse is slower than the apical pulse, and remember that indicates that there is some kind of cardiac issue. You will hear those two distinct sounds when you're listening to the heart, so the lub and the dub. An entire S1 plus S2, so a lub-dub cycle, is one heartbeat. If you're listening to an irregular heart rhythm, you would want to assess the apical and the radial pulse rates at the same time to determine if a pulse deficit does in fact exist. That pulse deficit is present when the patient's radial pulse rate is slower than the apical pulse because of cardiac contractions that are weak or ineffective at pumping blood to the peripheral tissues and extremities. A pulse deficit can indicate a serious cardiac event, and the patient's healthcare provider should be notified immediately. Always, again, be listening for murmurs when you're listening at those cardiac landmarks. They're more common in children and tend to disappear in adulthood, but they can still be, considered benign, but there are cases where murmurs are significant and need to have further investigation. When you're documenting, you want to document the location, characteristics, and intensity of the murmur so that it will help the provider determine if further diagnostic studies are needed. You would also note the murmur's location and if it radiates to other areas, and if a thrill, which is an abnormal vibration felt on palpation, is detected with that murmur. Murmurs are graded according to intensity, so grade 1, grade 2, grade 3, grade 4, grade 5 being the very loudest with a palpable thrill. Grade 6 is heard with a stethoscope off the chest, and the thrill is palpable and visible. If you note that there's an abdominal bruit or pulsation, that can be a sign of abdominal aortic aneurysm, which is a life-threatening emergency. And then peripheral vascular assessment, you will inspect and palpate the peripheral pulses. Absent pulses is a 0. 3+ pulses is bounding. And you want to assess the brachial, the ulnar, the radial, the carotid, femoral, popliteal, dorsalis pedis, and posterior tibial pulses should all be assessed. You're noting the intensity, the rate, and the rhythm, as well as the existence of blood vessel tenderness, tortuosity, which is the bending and twisting or nodularity of the area. Any kind of problem that might be identified can indicate an arterial or venous impairment. The Allen test is a test that is performed to evaluate for collateral circulation and determine the patency of the arteries of the hand before an arterial blood test is performed. And you do the Allen test by having the patient elevate the extremity and make a fist. The examiner will then occlude the radial and the ulnar arteries and should note that the patient's hand loses color. The patient would then open their fist and the pressure is released from the ulnar artery with the skin color returning to a normal pink within 10 seconds, and that indicates that there is good circulation. When you're assessing the brachial pulse, you would want to support the patient's forearm in an abductive position. The elbow should be slightly flexed and the forearm externally rotated. You will locate the anterior aspect of the elbow and palpate along the course of the artery just medial to the biceps tendon. And you will switch positions of the hands when you are assessing the opposite arm. The radial artery is palpated on the inner aspect of the wrist in the groove closer to the thumb, and on the opposite side of the wrist, the ulnar artery can be felt. The ulnar pulse is less prominent than the radial and is assessed only in circumstances in which the radial pulse is not able to be palpated. To assess for further venous or arterial insufficiency, of course, you want to observe the patient's skin characteristics, especially those in the lower extremities, when the patient is in both a sitting and a standing position, noting any swelling or redness, nodules, protruding superficial veins, or peripheral edema. You may note varicose veins, which are enlarged superficial veins that can result from pregnancy, obesity, advanced age, or prolonged standing. Dependent edema is most often seen in the lower extremities and is usually caused by venous insufficiency. And then gross amounts of swelling in the calves and lower legs usually indicate a more serious condition such as congestive heart failure or liver disease. Of course, you want to assess whether that edema is pitting or non-pitting. You want to know any phlebitis, which can be assessed and is typically due to irritation, often from IV solution or infection. You would note redness, swelling, warmth, and tenderness of the vein. If you have a patient that has arterial insufficiency, they most likely will exhibit the 5 P's of circulation, which is pain, pallor, pulselessness, paresthesia, and paralysis. There are other indicators of circulatory insufficiency, including a lack of hair growth over distal extremities, recurring ulcers of the feet or lower legs, and brittle or thin skin. Upon assessing the musculoskeletal system, of course, you're going to ask about any pain or stiffness of the joints, the patient's ability to perform daily activities, can they climb stairs and walk without limping, is there any numbness or tingling in their extremities, do they engage in regular exercise, or have they had any recent trauma or any chronic illnesses that would affect their nerves or musculoskeletal system, do they have any musculoskeletal deformities or family history that would be pertinent, and do they have regular intake of calcium and vitamin D. Upon inspecting the musculoskeletal system, you want to inspect and palpate the musculoskeletal system. You want to assess the patient's gait, their sitting position, how they change positions from lying to sitting, palpate the joints, note any postural irregularities, such as scoliosis, which would be a sideways or S-shaped curvature of the spine, kyphosis, which is an outward curvature of the thoracic spine, lordosis, which is a condition that causes an increased lumbar curvature just above the buttocks area. You want to assess the patient for any signs of osteoporosis, such as sudden and severe loss of height and back pain secondary to vertebral fractures. You want to have the patient sitting and then standing, evaluating the muscles, cartilage, bones, and joints for overall size, gross deformity, alignment, contour, symmetry, and position. If abnormalities are detected in any joint, you want to note the surrounding skin color and palpate for warmth and tenderness. If the patient has increased tone or hypertonicity, greater resistance will be evident on passive movement range of motion. If they have hypotonicity, a decrease in muscle tone, the muscle will feel loose and flaccid during passive range of motion. And you can assess the patient's upper extremity strength by having them squeeze your hands and push and pull against them. You can also have the patient push and pull against, push and pull each foot against the nurse's hands to provide an evaluation of their lower extremity strength. And then you want to document any differences that you find. Passive range of motion, of course, is when you assist the patient. Active is when they are performing the activity on their own. If the patient is independent, you can document that the patient can move all extremities. And then you also will assess deep tendon reflexes. Deep tendon reflexes can either be absent or diminished, and that is a result of any kind of defect of the muscle, sensory, or motor neurons. A lot of times if patients have an abnormally increased deep tendon reflex, that can be associated with an upper motor neuron lesion. And then you want to further assess and go and assess the nervous system for any difficulties, any weakness, tremors, loss of balance, mood changes, history of meningitis or trauma, pain, weakness, paresthesias, any alcohol or recreational drug use, exposure to pesticides or other chemicals. Those are some questions that you ask. And you would assess their mental status, their intellect, their behavior, their memory. Are they oriented to person, place, time, and event? You can test their level of consciousness using the Glasgow Coma Scale and perform an emotional assessment, assessing their stress, sleeping pattern, appetite, and weight loss or weight gain. The nervous or the neurological assessment would consist of both the central and peripheral nervous system and an assessment of the cranial nerves, which we've touched on a little bit throughout the presentation. A popular method for remembering the order of cranial nerves is use of the rhyming phrase, on old Olympic towering tops of Finn and German viewed some hops. And then in your textbook, you can further learn about the different functions of each nerve. But of course, you have your olfactory, your optic, you have your oculomotor, your trochlear, you have your trigeminal, your abducens, your facial, your vestibulocochlear, your hypoglossal, your glossopharyngeal, your vagus, and your accessory muscles. I'm sorry, accessory nerve. But those are your nerves. And then assessing sensory nerve assessment, you use a 1 to 2 point discrimination. When you're doing this assessment or the screening for sensory nerve dysfunction, you can do this while you're doing other parts of the physical exam, like the skin assessment, for example. You have the patient close their eyes and ask them, do they feel the dull and sharp sensory stimuli equally on both sides of their body? You can ask the patient to describe the quality of each stimuli and note the presence or absence of bilateral symmetry when the stimuli are applied to the patient's extremities and trunk. So you're going to compare distal with proximal sensations. Knowing the dermatomes of the body will help locate problem areas. And if you find any abnormalities like numbness, tingling, or lack of sensation, then you can perform further assessment. The gastrointestinal assessment, you would ask about pain or difficulty swallowing, weight change, lack of appetite, nausea, vomiting, abdominal pain, the patient's usual food intake, do they have diarrhea, constipation, blood in their stools, abdominal surgery, gallbladder disease, cancer, history of irritable bowel syndrome. You would perform an abdominal assessment, having the patient lay supine with their knees bent, inspecting for any abdominal distension, inspection of the color, noting any bruises, lesions, any venous pattern symmetry, auscultating the bowel sounds, and then palpating. So auscultating, listening for bowel sounds in each quadrant, and you would listen for 5 minutes on each quadrant before determining that it is truly absent. They can also be hyperactive bowel sounds or grumbling, borborygmi, I think that's how you say it. Or you can have absent, again, bowel sounds, which would be noted if you cannot hear bowel sounds in a quadrant for after 5 minutes. You want to palpate for tenderness and rigidity, note any guarding or any wave-like motion, and palpate the bladder area as well. When you're assessing, you want to note that it's the patient's right upper quadrant, the patient's right lower quadrant, left lower quadrant. And for genital urinary, you're noting any difficulty with urination, pain or burning when they urinate, history of a urinary tract infection, kidney infections, kidney stones, any change in frequency of urination, asking them, do they feel like they completely emptied their bladder when they urinate? Do they have to get up at night to urinate? For the breast and genitalia, you would ask pertinent history, health assessment questions. You would inspect, palpate the breast, and perform patient teaching, reminding patients to report any changes to their primary care provider immediately. Breast self-awareness is now recommended in place of breast self-examination, and women are recommended to have annual mammograms beginning at age 40, with a clinical breast exam every 1 to 3 years for women between 29 to 39 years of age. During the examination of the genitalia, of course, you'll wear gloves. You would inspect and then palpate from front to back, note any kind of enlargement of the inguinal nodes, note any abnormalities of the labia. In the male genitalia, for the male genitalia, a hypospadias and epispadias would be an abnormal finding, and you can see these pictures noting the placement of the urethra on the ventral surface in picture A and in the dorsal surface on picture B. During the assessment of the male genitalia, you can palpate, you can assess the scrotum and testes. Usually the left testes is lower than the right. Note any kind of lumps or swelling. If the patient has not been circumcised, you want to return the foreskin to its original position and continue to inspect the entire shaft of the penis, palpating by compressing the shaft between the thumb and the first 2 fingers. Note any tenderness or pain response, and document any lesions or scars. Any discharge should be noted as well. The scrotum area should be examined for any tenderness or masses. And it's important to note that the size of the scrotum can change with variation in temperatures. Lifting the scrotum toward the body in cold temperature and relaxing in warm temperature to protect the viability of the sperm, which are temperature sensitive. At the completion of the physical assessment, you want to give your patient adequate time to dress, offer any needed supplies, use PPE and infection control protocols, record your assessment, and report any serious abnormalities to the provider, and document patient education. And that is an overview of your physical assessment. Refer to your class resources for further questions. Some of the material did come from the Fundamentals of Nursing book that we use in first level, but you should also be able to refer to your ATI resources and get adequate information about physical assessment.